morning class. Today we're going to be talking about heart failure. We will also watch a video here at the beginning as soon as we go over the objectives. So the objectives for this lesson will be to contrast your left-sided and right-sided heart failure, discuss treatment of systolic and diastolic heart failure, apply the nursing process to a specific patient who is admitted with heart failure, and then by the end you'll be able to develop a care plan with somebody that has heart failure that has been admitted. So the definition of heart failure is that this is when the heart cannot pump enough to keep up with the body's metabolic demands. The 5 years that is on your PowerPoint, when somebody is diagnosed with heart failure, they usually die within 5 years of being diagnosed. So they don't live very long after diagnosis. African Americans are at a higher incident of developing heart failure. And then this can occur anytime when the heart is not unable to be prevented to fulfill functions to pump or to even circulate the blood out. So this can be diagnosed as mild to severe, or it can be acute or chronic. So it could be just something that occurs due to hypertension that may be corrected once we get the blood pressure under control. It will reverse the heart failure. Okay, Khan Academy is a really good source to watch videos. So this one we're going to watch of what heart failure is, and it'll go into some of the stuff that we will be talking about, like your systolic and diastolic heart failure, the lungs, and then you're having also back up into the peripheral areas. Okay, so when he was talking about that the heart muscles were larger, what condition do you guys remember from A&P that can cause that? What is that called? Does anybody remember?
When the what?
When the heart muscles are enlarged.
Isn't that like hypertrophy?
That's your cardiomyopathy, because you have that enlarged heart. Yes. So on this one, this is where that shows to where your heart muscles are becoming more weak on this side. So the more weak that your heart muscles are, the more it cannot squeeze enough to get that blood out. So another way to think of heart failure is, for example, you have, say, 500 cc's of blood in the heart. So, and it pumps out normally, like for us, it would normally pump out that normal 500 cc's, leaving roughly a little bit in the ventricles. But with somebody with heart failure, it will have that 500 in there, but it may only eject 300. So if you have blood left over, then that's what's considered heart failure, because it's not meeting the body's demands to get all of that blood out of the ventricles pumped out. This one is where the muscle itself is more enlarged. This is what it'll look like when they do x-rays. They'll do a chest x-ray to look at the enlargement of the heart. Okay, so the causes of heart failure: coronary artery disease and uncontrolled hypertension. Why uncontrolled hypertension and coronary artery disease? Why would those be big contributors?
Well, with the hypertension, the arteries and veins are constantly trying to maintain, so they're overworked.
Right, and so they become a lot weaker as the disease progresses if they're not controlled. And coronary artery disease,
Coronary artery disease for the atherosclerosis and the arterial sclerosis.
right, so then you're still not getting that squeeze because you've got all that plaque and everything in there building up to where those muscles become weak and you're not able to squeeze. Other factors can be just weakness of the heart muscle as we age. Our heart doesn't necessarily always work efficiently, it becomes weaker. Toxins such as other medications, drugs, illegal drugs like cocaine we talked about yesterday, and then cardiac dysrhythmias, the ones we started yesterday: VTAC, VFib, AFib, flutter. Okay, then your table there on page 425, these are factors that can precipitate heart failure. And these are the ones that we went over above. There. pathophysiology of heart failure. Two key terms to note are congestion and increased pressure. So, like he was saying on the video, it's like a traffic jam. Everything starts getting congested because the blood's not flowing out the way that it should, the heart's not working efficiently, and so you're going to have either that backup into the lungs or you're going to have that backup into the peripheral. Okay, there's two types of heart failure. You either have right side or left sided, and then your left sided can be systolic or diastolic, and you can, like he said, have it on both sides. Okay, so we said the congestion develops because it's unable to move that same amount of blood out that's coming in. So, and like Ashley had mentioned, the atherosclerosis, arteriosclerosis, what happens to your vessels? What do they start looking like? Narrowing, and they're narrowing, and then so what's going to cause them as they narrow? What are they going to do?
Push less blood through.
Okay, so what are we doing to the blood?
Constricting.
We're constricting those vessels. So then the resistance part comes with the muscle, the heart muscle getting more tired, and then that will lead to that increased pressure because they're trying to increase that pressure resistance to pump that blood out. And so that's what's going to cause the increased pressure. Right-sided heart failure is what we'll start with first. So right-sided heart failure, so where are we backing up into?
The bottom.
Okay, so I know it's right behind me, but what kind of signs and symptoms are you going to look for and assess on your client? Edema. Typically, where are you going to see that at?
Lower extremities.
The lower extremities. What kind of edema are you going to have?
Pitting.
Pitting, and it can be as much as a 3+ pitting to where you can like make your thumb imprint pretty far down into the skin. What other things are we going to notice?
The ascites and the
Okay, they're going to start building fluid up in the abdomen. Okay, they're going to become a lot tired. They're going to be more fatigued. Yeah, they're going to be weak. They're not going to be able to get around as much. Just like we talked yesterday, having those rest periods with activity. The jugular veins that we talked about yesterday, if you lay them in a semi-Fowler's position, how high up does it have to be and over what?
4 inches over the.
4
Not in
centimeters.
centimeters, yeah, centimeters, and then over the clavicle, yes. So, weight gain is going to be another one. That is how you're going to tell whether or not it's controlled heart failure. And then another thing is you're going to have an enlarged liver and spleen. So you'll be able, doctor will be able to palpate those, you would be able to palpate those because they are enlarged enough. Okay. The other things that you will, besides edema in the lower extremities, the sacrum is to where you're going to look for those people, especially if they're sitting, laying in bed, it's all going to start cooling down in that sacrum area. And so what do we got to watch for?
Bed sores.
Bed sores. We need to watch for breakdown because the edema on top of it already puts them at risk for breakdown because that skin is weak. And we said, and dyspnea is another one of their signs and symptoms that you will want to look for. Okay, so now left-hearted failure. So now we're moving into the lungs. What are we going to assess?
Lung sounds.
Okay, so what are we going to hear on lung sounds?
Crackles or wheezes.
Crackles or wheezes. Okay. What else are you going to assess?
They're gonna have like the blood pressure problems.
They could have blood pressure problem. We need to monitor their vital signs. Also, these people become confused at times, so then you got to, if they have a diagnosis of heart failure, that may be one indication that we're developing, getting worse. Your vital signs, tachycardia. What is orthopnea?
The elevation in the blood pressure when they stand up or sit down. Or
Nope.
where they have to lean over to breathe.
Yes. Yep. That's because they're having their respiration, they're having a hard time breathing. So then they get into that tripod position to where they're sitting over. You'll see a lot of COPD patients also in that position because it helps them expand their lungs as much as possible to be able to breathe. They become restless. Another one, you're going to see cough. Tachypnea is fast respirations, and then your blood tinge sputum. This is, what is that indicative of? Okay, say it loud.
Pulmonary edema.
Pulmonary edema. If they are coughing up pink, frothy looking sputum, they're in pulmonary edema. That is an emergency situation that you need to get diuretics on board. You may need to get something to help them relax. Definitely oxygen on board. We need to get that fluid off of them, failure. So now we're moving into the lungs. What are we going to assess?
Lung sounds.
Okay, so what are we going to hear on lung sounds?
Crackles or wheezes.
Crackles or wheezes. Okay. What else are you going to assess?
They're gonna have like, the blood pressure problems.
They could have blood pressure problem. We need to monitor their vital signs. Also, these people become confused at times, so then you gotta, if they have a diagnosis of heart failure, that may be one indication that we're developing, getting worse. Your vital signs, tachycardia. What is orthopnea?
The elevation in the blood pressure when they stand up or sit down. Or
Nope.
where they have to lean over to breathe.
Yes. Yep. That's because they're having their respiration, they're having a hard time breathing. So then they get into that tripod position to where they're sitting over. You'll see a lot of COPD patients also in that position because it helps them expand their lungs as much as possible to be able to breathe. They become restless. Another one, you're going to see cough. Tachypnea is fast respirations, and then your blood tinge sputum. This is, what is that indicative of? Okay, say it loud.
Pulmonary edema.
Pulmonary edema. If they are coughing up pink, frothy looking sputum, they're in pulmonary edema. That is an emergency situation that you need to get diuretics on board. You may need to get something to help them relax. Definitely oxygen on board. We need to get that fluid off of them.
You said it's pink and frothy.
Pink, frothy. Okay, and then of right heart failure, your first indicative sign is going to be edema in the lower extremities on right heart failure.
Is there one most prominent on the left side? Or is it just like the crackles and wheezes?
The crackles in your wheezes are what's going to be more, yep. Ventricle. So this is your ejection fraction. Does anybody know what a normal ejection fraction is? 55 to 70% is what normal is. So this is, ejection fraction is a hallmark to left-sided heart failure or systolic heart failure. So what is the ejection fraction going to be? Usually 35 to 40% is what is going to be out of the left ventricles. So this allows the body to increase that cardiac output when needed by increasing that force of contraction and ejecting that blood out. That is what your ejection fraction needs to do. It needs to be able to eject that blood out. If you're, hang on just a second. If it's lower, then we're not ejecting that blood back out very efficiently to meet the cardiac output. Your cardiac output is going to go down.
What did you say the ejection fraction is for the systolic heart failure?
It's 35 to 40%. Okay, so this is a good picture. I know it's a little hard to see on your guys' PowerPoint. So this is, I just Googled systolic versus diastolic, and this is what will come up. So it just talks about So what's going on between the two different ones? So systolic is going to be your impaired contractility. It's not going to contract as with much force. Your heart is going to be thin and weak. The heart muscle, you're going to have a low ejection fraction. And then it can be caused anywhere from ischemic heart disease to chronic hypertension, dilated cardiomyopathy, and myocarditis, which would be inflammation of the heart muscle. Okay, then your diastolic is going to be impaired filling and relaxation. This is when I showed you on the the first PowerPoint to where that muscle is thick. That's what it's going to look like. You have a normal ejection fraction with diastolic heart failure. So that would not tell anything if we did ejection fraction for diastolic. So etiologies are going to be hypertension with left ventricular hypertrophy, which is that enlarged left ventricle. Restrictive and hypertrophic cardiomyopathies, if fibrosis occurs within the heart. Scardosis, constrictive pericarditis, vascular disease, and just aging can be a factor. Okay, then diastolic failure, which I said it prevents that blood from filling and relaxing. This will have your decreased stroke volume and your cardiac output. So in heart failure, if it's filling and not being able to eject out, then that's when you're going to have your stroke volume and your cardiac output are going to decrease. They're not going to be normal. So, but you'll have, like I said, you'll have a normal ejection fraction. And the hallmark of diastolic is going to be your neck vein distension, your jugulars is going to be your hallmark sign for diastolic. Okay, diagnostic tests. We can do a chest x-ray, because that'll look at the size of the heart. An echocardiogram. Has anybody seen an echocardiogram done?
I've had one done.
You've had one done? What happens during that procedure?
I laid on my left side and they used the sonogram probe, and they looked at my heart and took pictures of it.
Yep. They look at all the structures of the heart they can look at. Why do they have you on your left side?
I'm not even sure.
We talked about it in class yesterday.
The blood flow?
Yeah, it looks at structures and everything, look at it more clearly. It brings it kind of out to the front there. And when you're listening for irregular heart sounds, like your murmurs and all those abnormal sounds, it's better to hear them when they're laying on their left side. It's more prominent. Electrocardiogram, your ECG, looking at the heart. They can do an MRI to look at structures also, but with an MRI, what can you not have in your body?
Pacemaker. Metal.
Okay,
Metal.
any type of metal you can't have. Electrolytes, complete blood count, we want to look at all that, plus look at cholesterol too, for the coronary artery disease. And then your brain natriuretic peptide, BNP, is what a lot of times this is what the physicians will use when they come in through the ED. This is an enzyme that's released in our body, and if it's elevated, if it's greater than 500 picograms per liter, then it's considered heart failure, that they're in heart failure. I've had patients that their BNP before has been in like the 2000s, so they are pretty well having issues with the failure. You also may get extra heart sounds like your S3 and your S4s.
I'm sorry, on the BNP, is that a blood test or?
Yes, it's a blood test. Okay, so then also other ways we can tell, what did I tell you about the weight gain? How many in 24 hours? 2 pounds, and how much in a week? 5. Okay, 2 pounds in 24 hours or 5 in a week. And then also, what else would you be looking for observing? What would you see? In here.
And where?
In here. Here.
Here.
Oh.
You would hear.
Crackle?
Okay? Crackles and wheezes.
And speed pitting edema?
Okay,
They're gaining weight that much.
Just
Oh.
struggling.
yep,
to breathe.
we're struggling to breathe, so dyspnea. Okay, so treatment. With heart failure, we need to identify and treat the underlying cause of heart failure. We can do this with drugs, we can do it with surgical procedures. Surgical procedures as far as putting in a biventricular pacemaker. They'll work on if there's any septal abnormalities, then they'll correct those with surgery. Okay, so according to the American Heart Association guidelines for heart failure, they want to, in 2013, that's the newest, they reduce the demand of the oxygen and workload of the heart, strengthen the heart's pumping action, relieve the venous congestion in the lungs, and then minimize the sodium and water retention in the tissues. Because wherever sodium goes, what follows?
Water.
And that's what causes our swelling. Okay, so we're not going to go through all of these medications. I just listed them because these are what they use to treat heart failure. Your angiotensin converting agents, your ACE inhibitors, your ARBs, which is your angiotensin receptor blockers. We use beta blockers. We use digitalis, which is the one that we will talk about because that is your digoxin or lanoxin. And that's what they use quite a bit to treat heart failure. Definitely diuretics because we want to pull what off? Fluid. We want to get rid of that fluid. And then vasodilators, so then that way we can help things expand to be able to move that blood throughout the body. Morphine, why would we use morphine? Okay, but there could be another reason why we use morphine, not just besides pain.
To help them breathe, calm them
Yeah.
down, relax.
That air hunger that they get. So you'll need to have them give them morphine to help them with that. And then oxygen, obviously. We want to put oxygen on them, whether we start with just a nasal cannula, that may lead into a simple mask, that could end up being a non-rebreather by the time we're at the end when they're really struggling to breathe. Okay, so the first treatment is, that we'll talk about, digitalis. The action of this is going to help increase that force of contraction. So when we talked about the heart muscle, you know, it's growing weaker, it's not pumping as well and efficiently. So now we need something that's going to help it to work more efficiently. So to squeeze the heart more and push that blood out, just like he showed you with the water bottle. That's basically what digitalis is going to do. And then it's also going to slow the heart rate down. So before you give digoxin, what do you need to do? Okay, take your apical pulse for how long?
1 minute.
Okay, what does it need to be?
50 or more? 60 or more?
60 or more, yep. They do say in some situations, even if it's below 60, they still give it. But typically, the doctor's going to write the orders if it's less than 60, do not give this medication because it'll drop the heart rate even more.
Why, cause I give a lot of like blood pressure medicines and they have that like limit too, like if it's below 60, don't give it. Like why would?
With blood pressure medicines, because you can, it'll drop it even more, is why, yes. Okay, so, and then adverse effects can be nausea, vomiting, diarrhea, headache, dizziness, are what common ones. Okay. So before I talk about toxicity, I want you guys to kind of get in groups of 4. The you can do is take your sponge and just lift it out. These aren't the best sponges in the world. Okay, so you see how little, like Nina has hers. See kind of how it's just barely dripping out of there? That's what heart failure is. So when you give the digoxin on top of it to help the heart failure, now put it back in the water. Now lift it out and squeeze it kind of slowly. These aren't the best sponges, but it'll give you the idea. It comes out more, it's going to work better. So it's squeezing more out versus if you just hold it up, it's just going to trickle down and then you can squeeze it and it's going to pump out blood more. Does that make sense? Okay. Okay, thank you. So the toxicity. So the ones we talked about before, the adverse effects, those will become worse with toxicity. They will become weak. You'll see mental or mood changes. And this is another big one, is yellow or green vision that they will start seeing when they become toxic. The antidote is Digibine. This will absorb all the excess dig that's in the system floating in the circulation. For normal digoxin is 0.8 to 2.0 nanograms per deciliter.
Please say that again.
0.8 to 2.0 Ng/dl. Okay, so other treatments like I had talked about, we can do surgeries. These are the surgeries that could be possibly done. The nursing process, this will help develop your care plan. So we need to get their history, identify what the problems are, ask about clotting and accessories, if anything else is going on. So, and then we need to talk about edema. Are they having any edema anywhere? What kind? Is it pitting, non-pitting? Are they able to keep an accurate weight record? And then feeling of breathlessness or catching their breath mid-sentence. You need to ask these types of questions. Are they able to carry on a conversation with you without getting overwinded? And then do they have crackles or wheezes in their lungs when you listen to them? Okay, so continue with the assessment. You're going to inquire about their activity level. Are they able to maintain a normal activity level? Are they having to do a lot of resting in between because they get very short of breath or dyspneic? Paroxysmal nocturnal dyspnea. This is when they have to get up in the middle of the night to go to the bathroom. And then ask about their medication compliance. Are they taking their medications the way that they should? And then assessing their diet. Are they eating a lot of high sodium foods? Are they eating the proper amounts of fruits and vegetables, kind of a balanced diet? And then their smoking history, because it'll affect their vessels.
The dyspnea, like, are they getting up because they can't breathe and then they use the bathroom, or what?
It'll wake them up in the middle of the night, they're breathing.
Okay.
Yeah. Okay, then your nursing diagnosis and planning, you need to make sure that you plan extra time when you're going to go in and ask them questions to develop your care plan, because they will fatigue. Look at their lack of mobility. Are they able to get up and around? And then are they oxygen deficient? Do they need oxygen to help with their dyspnea and their shortness of breath? Then your criteria, obviously you're going to make it to each patient. Is going to be specific. Not everybody across the board is going to have the same care plan or the same interventions. Implementation. So when we implement these, you want to talk about self-care, because a lot of these patients will still go home with heart failure. So that you need to have them balance between rest and activity. They may just let them know about their diet, how they need to modify their diet, be compliant with their medications. Keep up with their immunizations. Why do we need to worry about immunizations with these clients?
Help them fend off,
Pneumonia.
like pneumonia and.
Right, they're going to be more susceptible to get the influenza, pneumonia, especially your elderly.
Depleted. Their immune system's depleted.
Yes, their immune system is kind of, you're having a hard time fighting off anything that they may have or catch. And then what symptoms do you want them to report to you? Increased dyspnea, swelling, their weight gain would be one. If they gain 2 pounds in that 24 hours, they need to be calling the doctor's office to let them know so they can get in to see. So the Healthy People of 2020 objective is to reduce hospitalization with heart failure of the older adult. You want to monitor electrolyte values. Which one are we most concerned with?
Sodium.
And, yep, because this is what causes this, cardiac dysrhythmias. So we need to be